Good afternoon. Thank you for prioritizing your time to join us for this important discussion today. My name is Cami Berardi, and I'm an Associate Project Director here at NICHQ. Before joining NICHQ, I led the public information and outreach efforts for the state-based health insurance exchange in Massachusetts during the implementation of the Affordable Care Act. I was responsible for training and working with state advocates to help thousands of families manage their transition into new health insurance coverage. My career in children's health advocacy developed during my time as a federal lobbyist and grassroots advocate for the Children's Hospital Association, as I worked to ensure that all children had access to the right care at the right time. Today's call is organized around the following objectives. We hope that you'll learn about the prevalence of maternal depression and its effect on early childhood outcomes and health disparities. We look forward to sharing the latest recommendations for maternal depression screening from the U.S. Preventative Services Task Force. We plan to explore some strategies for improving access to screenings and interventions that we believe will help you define actions that you can take at both the community and state and at the federal level to help more mothers and families get the support that they deserve. Please note that we will be sharing a recording of this webinar after today's call. We're honored to be joined by our esteemed colleagues and from well-respected organizations, all of whom are experts about and advocates for maternal depression. Each will be presenting on different topics and different aspects, of maternal depression and its impact, and I look forward to introducing them in more detail as they present. Before we jump in, I just want to provide some quick background on NICHQ and why we're passionate about this topic. NICHQ is a nonprofit organization that for 20 years has solely focused on driving dramatic changes in the complex issues that face children's health. As you can see from our mission and our vision, which no doubt is not dissimilar from many of yours, at the heart of what motivates us is the belief that children and families deserve better systems and better support so that every child achieves their optimal health. Because of this belief, addressing social determinants of health and eliminating health disparities is central to our mission. Our commitment to taking a two-generation approach to children's health, one that supports the caregiver-child dyad, is illustrated in the improvement initiatives you can see here. From addressing social determinants of health that affect early childhood health outcomes, such as housing and unemployment, to empowering parents to be advocates for their children's social and emotional health. NICHQ is currently the National Coordinating Center for the Early Childhood Comprehensive Systems COIN, or fondly known as the ECCS COIN, a Health Resources and Services Administration-funded national initiative seeking to improve outcomes in developmental health and family well-being. We have also been funded by the Robert Wood Johnson Foundation to enhance the ECCS COIN's policy and advocacy efforts. As the focus on Medicaid's role in early childhood outcomes became clear, so too did it become clear to us that we could meaningfully address a simple policy change to ensure that all caregivers are screened for depression in the Well Child visit. That's why we are focusing this webinar on maternal depression and its effect on maternal and child health. We are really excited to share our learnings with you, the health professionals, the advocates, families, stakeholders that are joined with us today so that we can improve outcomes for mothers and babies across the country. We just again want to thank Robert Wood Johnson Foundation's Healthy Child and Families team for funding this important webinar. Dr. Reeves, we're thrilled to have you, and we're really looking forward to your insights. Dr. Reeves is a senior fellow in economic studies at the Brookings Institution, where he holds the John C. and Nancy D. Whitehead Chair. He's the director of the Future of the Middle Class Initiative and co-director of the Center on Children and Families, and his research focuses on the middle class, inequality, and social mobility. Dr. Richard Reeves' publications for Brookings include the latest book, Dream Hoarders, How the American Upper Middle Class is Leaving Everyone Else in the Dust, Why That Is a Problem, and What to Do About It, Time for Justice, Tackling Race Inequalities in Health and Housing, among others. He's also a contributor to The Atlantic, National Affairs, Democracy Journal, The Wall Street Journal, and The New York Times. And in September 2017, Politico magazine named Dr. Reeves one of the top 50 thinkers in the US for his work on class and inequality. From 2017 to 2018, he served as a member of the Government of Canada's Ministerial Advisory Committee on Poverty. Dr. Reeves is also a policy consultant to the Opportunity Insights team led by Professor Raj Sheta at Harvard University, an advisor on the American Family Survey, and serves on the board of Jobs for the Future. Dr. Reeves, you're well accomplished. We're thrilled to have you here. You now have control of your slides, and we're looking forward to your insights.
Thank you. Thank you for that kind introduction. And I hope we get back to Elaine and her story. And I'd like to thank NICHQ for the honor of presenting this work. I should say that I wouldn't describe myself as an expert on maternal depression by any means, although like many have some family experience with with both depression during and after pregnancy. My expertise lies in the field of inequality and intergenerational mobility, and so the work that I'm just going to briefly describe now actually came out of a desire to try and make more of a connection between some debates which I think are too often separated, which is around mental health care, and in particular issues around maternal mental health and issues of intergenerational inequality and mobility going forward. So that's what I'm going to speak to today. As I advance my slides, you should be able to see that earlier this year produced a report on the effects of maternal depression on early child development and the implications for economic mobility. And so I'm just going to give a brief summary of that work now. And the main message really that we're trying to get across in the report is the sense of everything being connected, and connected in this intergenerational way. And so if we can think about these different issues in separate buckets, but of course they're all related to each other. So the being low income, being in poverty, increasing the risk of mental health problems, including maternal depression, that in turn threatening some of the attachment which we hope to see with young children, which in turn affects child development, which in turn affects the outcomes for children and adolescents into adulthood, which then affects their own risk of poverty. And so that sort of part of that cycle is explained through this kind of important mechanism of kind of good mental health for parents, and especially for mothers. And so what I do is just briefly describe the kind of links in this chain before turning to some potential areas of policy solution, which is where I think some of the expertise of others will really be helpful in this call. So first of all, to just talk about the link between poverty and risks of maternal depression. And you can see from work we draw on quite heavily the Center on the Developing Child at Harvard, who've done obviously a lot of the work in this area. So much of our work is drawing on them and seeing how, just descriptively, the risks of maternal depression being greater for those in low-income families. It's not a surprising finding. The gradient is quite strong, and there are obviously all kinds of reasons why that would be the case, but simply establishing from the outset that we are seeing a connection here between poverty and maternal depression. And now here, drawing on work from my former colleague Julia Isaacs, who published here at Brookings, again showing risks of depression among mums being much higher if they're low income, poor, from the bottom one of those bars, and I'll come on to the rest of this chart kind of in a moment. So that's kind of connection one. Poverty tends to increase the risk. Then to see what's the relationship between maternal depression and attachment. And again, here we're just drawing on the work of others. This is not our area of expertise at all, so it's derivative as we form our logic model. And I won't go through all of these references, of course, but you can see from people like Field and Kessler and Bieber that there's pretty good evidence that you can see how the connection is made between being poor, then into problems with depression, mental health generally, and the ability to engage in kind of successful attachment. And in fact, to go back to this original slide from Julia, you can sort of see that there are also these gaps in cognitive stimulation and what she calls from the ECLSY maternal supportiveness. Should say she's using these terms, in the scientific sense rather than in a kind of judgmental sense. But the findings are nonetheless pretty striking. It's obviously much harder if you're struggling with mental health. And here from the Center on Developing Child, a long quote, so I'll pull out a couple of particular points, which is why, if you are chronically depressed especially, how much harder that is to engage in the kind of serve and return interaction, which we know is important for child development. And so there's this kind of sense of being hostile. It's hard to kind of serve in a way the child can return. And then relatively, if a parent, because of mental health problems, is withdrawn, the child can serve, but the parent doesn't return. And so that kind of interaction, which those of us who've had kind of and raised young children know very well, is very important to their development. And so that's the first two links. And then from weaker attachment to slower child development, what does it mean if you struggle with attachment? And then in terms of your kind of subsequent development, especially in the early years. And here again, I'm drawing on Julia's work, where what she does is she actually looks at school readiness. So when you're entering pre-K or K, kind of how ready are you on a series of cognitive and non-cognitive scores, and then running a whole series of quotes risk factors for school readiness. And here on this bar chart you can see the overall figures, and then the purple ones are the ones with controls, because obviously they're all highly correlated, and so you want to do running controls for other factors. A number of things jump out. There's a gender gap towards the top, but really it's towards the bottom that I would want people's focus to be around depression, maternal supportiveness, and kind of cognitive stimulation, and having statistically significant implications for the child being ready for school. And so you're seeing the kind of links in the chain at each step of the way. And some evidence more recently, this is from Child Development last year, from Matt Gagne and others, and again, not my field, so I won't be able to answer technical questions on it, but looking at the relationship between attachment and executive functioning on various measures, and how you can sort of see the children who are seen as having low attachment security on their measures, having lower levels of executive functioning. That gap does narrow over time, but the gap still remains for those children. So we're seeing that into K, and then the gap is still significant in grade 2. And here's the quote from that study as to what's happening there. And that kind of importantly here is that there seems to be a general effect on executive functioning, to use that phrase, rather than on kind of specific particular forms of executive functioning. So there's a more general effect on that kind of development in those years. I'm obviously going very quickly through this data, but it's all contained in the full report. And then some more from the Centre on Developing a Child, which is looking actually into adolescence, where you can see the cortisol levels, which is used by many researchers as a sort of proxy for levels of stress and hardship, being higher in adolescents who experienced maternal depression when they were themselves an infant. So you're seeing in this case, sort of decade and a half later, still some effects. And then the effect of slower child development on worse outcomes is well established. These I can skip through because certainly in social science, these are very well known facts. So Greg Duncan's work, for example, showing that children with if you're more school ready at age 5, that you can still see the effects of that all the way through grade school, high school, and even into your own adult earnings. And that's with strong and robust controls for other differences in family background. And we also know that those who graduate high school with lower GPAs are less likely to complete college, and so on. And the measures of cognitive ability in adolescence strongly predict your chances of being upwardly or downwardly mobile. So that's just the next link in the chain, which is how, if you have a weaker start in school, that obviously makes it harder to go on. I should say, of course, that these are averages, and that there are very, very many children who go in the opposite directions. So we are just looking here at some of the overall effects. It's certainly not true for everybody by any means. And then if you struggle through education, if you are one of those who struggle through post-secondary education, then you are more likely to be poor. So just a chart pulled for the purpose of this presentation. It's not my work, but it's good analysis of CPS, just showing the differential risks of unemployment by education level, and then earnings by education level. An obvious finding that these things really matter into adulthood, and so the risk of being poor being much greater if you've struggled through to get the human capital education that you need. So that's the sort of a very, very quick story of the logic model. And so then when we turn to solutions, we're a think tank, so always trying to sort of move to solution space. And in very crude terms, having seen those connections, the way we've thought about this in terms of a framework is to say, well, we can reduce poverty. We can reduce the impact that poverty has on depression. We can try and reduce the impact that depression has on the development of the child in the household. And we can try and reduce the impact of early child development on later outcomes. So try and intervene at each of those stages. And I'll say just one or two things on each. So first, to reduce poverty, I'm going to skip pretty much through this slide. The point simply being that there are many ways in which we could reduce income poverty. And if income poverty is a risk factor for depression and everything else, well, one straightforward way to tackle that is by anti-poverty measures. And so, for example, just expanding the child tax credit could reduce poverty by about 1.5 million people for about 200 billion over 10 years. And there are many other examples in here, but I won't dwell on them because it's a straightforward calculation, if not straightforward politics. But I don't want to skip over the important point that we can address poverty by addressing poverty. But to reduce the impact of poverty on depression, perhaps a little bit more relevant to this particular conversation, is to say, okay, given that there are going to be some low-income parents and families, what can we do to try and break that connection between being low-income and the risks of depression? And so some of the, again, drawing on the literature and from people who are on this call know some of this very well, better than we do. Policy proposals such as mandatory universal screening, which you see in some states. There's a variation around that now by state, and so that's something for state policymakers to think about. The American College of Obstetricians and Gynecologists suggesting postpartum care for 12 weeks. And I think also sometimes we don't spend enough time just thinking about straightforward training, particularly for kind of providers, and how that might be effective, so that given that we will have low-income families, how do we help to somewhat insulate the risks against that, leading to higher rates of maternal depression, and then to reduce the impact of depression on early child development. So again, I think the early figures suggesting that there's always going, this is a naturally occurring phenomenon to some extent. A number of children will have the experience of having a parent or a carer who is depressed, and so are there ways to kind of help, even if we can't necessarily catch the depression in time, to reduce the impact of that on child development. And here again, I won't dwell, but we just go through some of the literature that's been the evaluation on various interventions, including legacy, ABC, etc., to try and help those families to, even if the depression itself remains to some extent, to actually still nonetheless improve some of the functioning, in particular, and the attachment. And then we just show on the evaluations again from Harvard of toddler parent therapy and what that can do for cognitive development. And here you see the kind of their measure of cognitive functioning for toddlers for those who had depressed non-treated mothers on the left, those who had depressed mothers who nonetheless went into the therapy, and then non-depressed mothers. So I think it's kind of importantly here is what we're saying is it's much more about the relational effects of the depression rather than just the individual. And then lastly, to try and reduce the impact of early child development on later outcomes. And here we're switching back into sort of social science space. And again, so I won't say too much here, but there is very good evidence that tutoring, both in high school, post-secondary, mentoring programs, making it easier to get into college, etc., and giving more support to those who are in post-secondary education to get through it. So in other words, sort of, it's never too late, in other words, to try and help people, even if they've had difficult starts. This is a continuous and intergenerational process, and essentially to try and tackle this at every single level. So the conclusions of our study are that we should see maternal depression as an intergenerational economic mobility issue. It's clearly lots of other things beside that, and this is not the most important thing that it is. But it is nonetheless something that should be taken seriously by those who work in the space of inequality and mobility. Everything is connected, that we see the steps in the cycle around intergenerational mobility, and this being an important part of that. We should be seeking to break the cycle of intergenerational disadvantage at each and every stage, and above all, to put mental health, and I would argue especially maternal depression, at the center of the mobility debate. Thank you.
Thank you so much, Dr. Reeves, for sharing those compelling insights. Dr. Karina Davidson, we are fortunate to have you here. Dr. Davidson is the Vice Chairperson for the U.S. Preventative Services Task Force and the Senior Vice President of Research, Dean of Academic Affairs, and head of the New Manhattan-based Center at the Feinstein Institute of Northwell. She's also a professor of behavioral medicine at the Zucker School of Medicine at Hofstra Northwell. Her research program focuses on innovations in personalized trials to manage chronic disease and patient symptoms that incorporate patient preferences and values. She's conducted randomized control trials on depression screening and treatments for healthy, hypertensive, and cardiac patients. Dr. Davidson has authored over 250 peer-reviewed articles, numerous editorials, and book chapters. She's won national and international awards for her research accomplishments and has served as the president-elect for many of her professional societies. Dr. Davidson formed and is the past chair of the Evidence-Based Behavioral Medicine Committee, a task force charged by 7 national and international societies with improving and implementing evidence-based principles within behavioral medicine. She's seen as an innovator in educational programming and has won university-wide awards for her teaching, mentoring, and innovations in curriculum development. Dr. Davidson joined the U.S. Preventative Services Task Force in 2014. We're thrilled to have you on this call. Thank you for taking the time, Dr. Davidson. That you have the floor.
I'm absolutely delighted to be here, and I thank NICHQ for inviting me to talk about this incredibly important topic. I'm sorry that we didn't get to hear the completion of the first presenter, but I hope we'll be able to hear that at the end. My talk follows very nicely on the previous one because I am going to be speaking to you today, not necessarily about the ways that maternal depression affects others, but what we can actually do to prevent the occurrence of maternal depression. So the United States Preventive Services Task Force looks at screening or behavioral counseling or preventive interventions. For this particular topic, that was a new topic for us, we reviewed all of the evidence on what could actually prevent perinatal depression. By perinatal depression, we mean those depressions that occur or develop either during pregnancy or up to 1 year after childbirth. And as many of you on this call know, that affects as many as 1 in 7 women. It is one of the most common complications of pregnancy. And so that's almost 180,000 mothers annually who suffer from this illness. We can, as you were told previously, it results in adverse short and long-term effects for both the mother and the child. And what we were excited to find out is that there's convincing evidence that effective counseling interventions can actually help prevent perinatal depression before it develops. That means that these particular interventions are aimed at those who are not currently depressed. And so in 2019, we came out with a recommendation with a grade of B. A B or A means that we are recommending this particular behavioral counseling intervention and that it should be available to those who would benefit. And when we judged the evidence, we saw that the net benefit outweighed any of the risks and harms for providing this to those who needed it. This particular recommendation is aimed at those who are at increased risk for perinatal depression, but not those who have already been diagnosed with the condition. Currently, we have no accurate screening tool available to assess the risks of perinatal depression, but there are certain factors that clinicians can use to determine risk. At the end of this talk, I'll be speaking about ways of concretely thinking through for patients and for persons who are pregnant or postpartum, if they might be in that risk group. For example, those persons who've had a personal history of depression, or who have a strong family history of depression, or who have elevated depressive symptoms but are not yet at the level that meets diagnostic criteria for depression, and certain socioeconomic risk factors, like being young or a single parent, may also be persons who are at increased risk and may benefit from these preventive interventions. So in reviewing the evidence to determine what would be most beneficial, we looked at many different types of interventions. We looked at physical activity, infant sleep education, in-hospital perinatal education, peer counseling. Each of these showed potential but limited evidence. We specifically, as a task force, have asked for more evidence and more randomized controlled trials, testing these kinds of interventions so that we can determine if they are, in fact, have net benefit. What we did find evidence to support in our recommendation was 2 counseling interventions: cognitive behavioral therapy, which addresses the negative thoughts and increases positive or pleasurable activities and actions, was found to be beneficial, and interpersonal therapy, which focuses on an individual's relationship with other people to improve communication and to address the problems that contribute to depression. We had 17 randomized controlled trials of these types of counseling interventions. We had over 3,000 women who were in included in these trials, and they were primarily pregnant as opposed to postpartum. The typical intervention was about 8 weeks long. There were about 8 sessions. That means there was about 1 session a week, and they were both group intervention settings as well as individual. If this type of evidence-based counseling is offered and received, there was a 39% reduction in the likelihood of depression, which is considered a fairly large effect. So for those who are considering how to implement this particular preventive counseling intervention to women with one or more of the following risk factors, you would look for someone, as I mentioned, who had a history of depression, who had current depressive symptoms, who had risk factors or socioeconomic risk factors that put them at increased vulnerability through pregnancy or postpartum to become depressed, those who've had recent intimate partner violence, and those who have other mental health related factors such as anxiety symptoms or a history of negative life events. We urge clinicians to carefully review past medical history and risk factors. Although we don't have any adequate evidence to make an evidence-based judgment of the timing of referral, we can tell you that most of the interventions that were beneficial were initiated during the 2nd trimester of pregnancy. And finally, to start wrapping up, I'm going to tell you about 2 related but important recommendations we also have to support helping women and persons who are pregnant and postpartum with depression. In 2016, we issued a B recommendation for the general adult population, importantly including pregnant and postpartum women, and we were recommending that screening for depression occur for all of these groups when there is adequate systems in place to ensure accurate diagnosis, effective treatment, and appropriate follow-up. This screening recommendation interleaves with our new preventive intervention for preventing depression, I think in an important way that I just want to mention. We're recommending everyone be screened. If someone is screened and is depressed, who is pregnant or postpartum, we want immediate treatment to be initiated. If someone has elevated symptoms, then the preventive intervention recommendation comes into play. So this is a way to find those women who aren't yet depressed and who can benefit from a prevention intervention. The second related recommendation is our recent B recommendation for intimate partner violence and abuse of the elderly and vulnerable vulnerable adults, and specifically women of childbearing age. We're also recommending that clinicians screen women for intimate partner violence, and this would be another way to find women who are not currently depressed, but are pregnant or postpartum, who have been a recent victim of intimate partner violence, who then would benefit from the preventive interventions. And so I know this has been a short introduction to our work in helping those who either should be screened for depression, who were found to have depression and so should be treated immediately, and those who are at risk for developing postpartum or perinatal depression and who can be helped to prevent it. Thank you.
Dr. Davidson, thank you so much for that insight and your comments. And I just want to remind all those listening that we have recorded, we will be recording this webinar to share, and we look forward to hearing both from Dr. Constance Gill and Elaine momentarily. Again, thank you, Dr. Davidson. That was very helpful information, and I look forward to the questions that we've seen come in on the chat. Dr. Gill, when you're speaking, we just ask that you speak closely into your microphone so that we can hear your comments. So I'll do a brief introduction. Dr. Constance Gill is an associate professor in the Department of Psychiatry and Behavioral Sciences and Obstetrics and Gynecology at the Medical University of South Carolina. She's the director of the Reproductive Psychiatry Fellowship and Women's Reproductive Behavioral Health Program at MUSC. So this program provides mental health and substance use treatment to pregnant and postpartum women, both in person and via telemedicine, in obstetric and pediatric practices in South Carolina. Dr. Gill is the recipient of a private foundation and federal funding from the National Institute on Drug Abuse to develop and evaluate treatment interventions for pregnant women with perinatal opioid use. Dr. Gill, the floor is all yours.
Great, and thank you so much for including me in this webinar and for the introduction. I'm thrilled to be here. There's really wonderful panelists, and so I'm really excited to have our discussion after myself and Elaine give some presentations. Can you hear me okay? Is that, and just let me know if you cannot. So what I plan to talk about is just a little bit more about how to actually implement some screening, what we do around kind of the treatment end of peripartum depression, and then some things that people can hopefully take away to do in their communities going forward. And so what was so nicely highlighted already by Dr. Davidson is that we should be screening all pregnant and postpartum women for mental health problems and substance use, and in particular, we should be screening for depression during this time. These are all the agencies that support that recommendation. And as Dr. Reeves had highlighted, a reason why we are screening for this is that we know that the health consequences of peripartum depression for women, for their partners, for their families is so severe, and it is something that we need to be identifying and promptly treating. So I think in this conversation, it's really helpful to figure out kind of where we're starting from in this kind of attempt to screen and treat people. These were some data about a few years ago that basically demonstrated that we were only picking up about 30 to 50% of women that had that had a diagnosis of depression in pregnancy and postpartum. And this is out of, say, 100 cases of people that actually have that diagnosis. We're only identifying 30 to 50% of these women appropriately. We're also only getting about less than 20% of these women into treatment, and as you can see, less than 10% are getting adequate treatment or achieving remission. So we know that a large part of this has to do with the fact that we are not screening. There's some good screening going on across the country, but there is room for improvement. But we also know that in people that are doing these screenings, they may not have training in the assessment and diagnosis of mental health problems and may not feel equipped to be able to do that. Another problem is that you may screen and you may diagnose, but you don't have any place to send these people to get treatment. And you might actually have places to send people, but sometimes the wait times for those appointments are so long that they are actually unhelpful. And then lastly, we also know that women do not often want to go see a psychiatrist or do not want to go get mental health treatment. So these are kind of the barriers of care that we think about when we're trying to implement programs to effectively screen and diagnose and treat women with peripartum mental health and substance use problems. So the good news in this is that we actually have some really good screening tools. The Edinburgh Postnatal Depression Scale is a very well validated screening tool for depression in the pregnancy and postpartum period. It only has 10 items. It's very brief. It's got a very good sensitivity and specificity for the probability of a diagnosis of depression if you use a cutoff score of 13. It's important to note, though, that even a cutoff score of 10, about 20% of those women will also endorse suicide ideation. So using even a lower cutoff score, you're still picking up a significant amount of maternal mental health problems. I will talk about the patient health questionnaire for two reasons. One, it's actually well validated as a screening tool for depression in pregnancy and postpartum. And two, it's often already integrated in a lot of healthcare systems. And it's a great screening tool because it essentially goes through the DSM criteria for depression. All of the items on the scale are what we use to diagnose depression. You basically just add up the highlighted area and you get a total score. And again, using a cutoff score of 10, we have a really good sensitivity and specificity for a clinician-rated diagnosis of depression during this time. One thing that I really like about this scale too is that it gives us a sense of the severity of symptoms, and so we can use that to monitor treatment over time. And then also importantly, those severity of symptoms map onto the appropriate level of treatment that we should be providing for these people. So it just offers really good guidance for clinicians in screening and treatment. So those are our two screening scales that are very helpful. What I wanted to talk about next is that oftentimes we screen and great, we identify people, we may even have a place to send them, but a really important next step prior to sending someone to treatment is the motivation to get them there. So often women will say, you know, yes, I'm struggling with depression or anxiety, but it's only affecting me, and that's okay. As long as everyone else is okay, then this is fine. I can suffer with this for a little while longer. But what women often don't understand is that their depression, their untreated anxiety and depression is having a really significant impact on their relationships and also on their child development, which was really nicely highlighted earlier by Dr. Reeves. And so we spent some time talking to women just about this and the impact of this illness, really to help kind of motivate them to take that next step to get into some treatment. So how do you do this? So folks that are just thinking about implementing this and finding places for treatment, you can reach out to kind of local mental health providers. A really great resource is Postpartum Support International. If you go online and look at their website, you can actually go in and find a local provider just by typing in zip code. So you'll find a number of people that specialize in maternal mental health and treatment, and that's a great kind of build of your referral list. Every state typically has departments of mental health where you can find mental health agencies in various counties, hopefully most of the counties in the state. And then Psychology Today does a really nice job of publishing people that are in your area that are therapists, and then you can go in and vet those people yourself. But is a great resource to just get started with building a referral list. What we would love to see happen is actually an integrated treatment model where we have mental health providers that are in obstetric and pediatric practices. This does a lot of things just in terms of continuity of care, having providers being able to talk with each other. It helps a little bit to destigmatize mental health from women's perspective, and that they're going in for obstetric or pediatric care, and this is just part of their routine care. And so this is really kind of the ideal model. And you really can use any level of mental health provider, everything from a master's to social work to a psychiatrist. It really just depends on what your setting is like. Our program that we have at MUSC, and really I would just want to talk about this in terms of lessons learned, and hopefully that's helpful to other people. So we embed our maternal mental health services into obstetrics and pediatric practices, and we do this in person at MUSC, and then we also use telemedicine. South Carolina is a very rural state. Telemedicine is a great tool to reach out to other obstetric and pediatric practices to create a virtually integrated care model. One of our biggest lessons learned is that we do not schedule new appointments for patients. And the main reason is that the need is so great that we will get booked 6 to 8 weeks out for new appointments, but that's way too late for someone to wait, and often they don't. So then people don't show up for those appointments. So we created what's called a walk-in clinic. So any patient, any woman that is needing a mental health evaluation can walk into our clinic. We have 2 mornings a week where they come in and they will get seen and evaluated right away. And we think that's really important because we think if there is an identified mental health need, these women should be seen in less than a week. And so that's kind of what we've created in our program. And then also in our program, usually the provider that saw that person when they walked in is going to be the provider that's going to do the continuity of care in terms of therapy and medication management if needed. So telehealth, again, as I mentioned, this is another tool that we have used in our state to try to deliver mental health treatment to pregnant and postpartum women and obstetric and pediatric practices. Another model that is a just really wonderful model in Massachusetts, it's called MCPAP, which is Massachusetts Child Psychiatry Access Project for Moms. It kind of builds on this child psychiatry program, but it's now for moms, and what they have essentially done is created a network of pediatric, obstetric, family medicine practices that have a direct connection to a perinatal psychiatry provider or someone in maternal mental health. So the provider seeing the patient in their practice and coming across a woman that has a mental health problem can then reach out to kind of a specialty provider to get consultation on what should I do here, what are next steps. And they can offer everything from here you should get them into the specialty treatment to here are some resources in your area or here are some referrals to get this woman care. So I just want to talk briefly about some of the legislative aspects of improving maternal mental health care. These are states that have done an amazing job in getting their state legislation to pass the requirement of screening and also requiring education and creating awareness campaigns and also perinatal depression task force. And I mention these because oftentimes, when you're sitting in a state that doesn't have anything like this and you're trying to think about, well, how do we even do this? Know that other states have done this and they have, you essentially have a blueprint for how to do this or how they've actually done it, and reaching out to those people to learn how they've done it is often a really good step. On the federal level, we're really fortunate in that from the 21st Century Cures Act, we had this Bringing Postpartum Depression Out of the Shadows Act that was passed in 2015. That gave monies to a number of different states that were working on implementation of perinatal screening and treatment. And those states needed to work with their state Center for Medicaid and Medicare so that that they were actually creating a model that would be sustainable over time, which is really important. And what I'll also say just lastly very quickly is the Moms 2020 is another really great organization that has done a ton of work around lobbying for more states to be able to screen and treat women with maternal mental health problems. And I'm very excited to pass things on to Elaine DeKine to hear more about her story.
Thank you so much, Dr. Gill, for walking us through both your clinical perspective and guidance on this topic, and then in particularly highlighting those motivators and resources for treatment. We are so thrilled. And Elaine, thank you for bearing with us. At NICHQ, we know how important family voices are and how they're needed to inform this work. So we can't overstate enough just how important your story and advice is to moving this work forward. I want to just do a brief introduction in the event that folks couldn't hear me as we load up your slides.
Okay.
So Elaine DeKine is the Executive Director for Postpartum Support Charleston, which is a local nonprofit providing peer support to moms in the Charleston community struggling with maternal mental illnesses. She herself received support from an organization as part of her own journey to recover from postpartum depression after she had her eldest daughter 6 years ago. She currently lives in Mount Pleasant, South Carolina with her husband and two beautiful girls, ages 6 and 4. And this afternoon, she's going to share her story and her work with us, which will help illustrate, as many of us know, the critical need for not only maternal depression screenings, but also access to these supportive services. So Elaine, thank you again for bearing with us.
Yeah, sure. So I hope that everyone or most everyone can hear me now. Should I do any sort of test or just go ahead?
You are good to go, Elaine. Thanks so much.
Okay, great. Yes, so thank you for the introduction. I wanted to start by sharing my pregnancy and birth story. I had postpartum depression after the birth of my first child. I became pregnant with her in November 2011. It was my first pregnancy, and it was a planned pregnancy. It was very easy. I was very happy, pregnant, expecting mom with no complications. I saw an OB that came highly recommended, really in the community, and is still today. But I didn't do any particular research on who my provider would be. So I didn't get any screenings from my OB provider and had no education on postpartum depression or anxiety being something that I might experience during or after my pregnancy. Looking back, I do know that I had some anxiety in my third trimester. It was never something that I brought up simply because I didn't realize that it was something that I should talk about. But it would have been great if it had been caught in that third trimester. with some type of screening. I delivered 10 days past my due date, and I was induced, which is not something that I wanted. So that, again, really kind of fed into my anxiety, and having a medicated birth was something that I worried about. And then when my daughter was born, she had really some very minor health complications. But again, because I was already in that anxious state, it really sort of escalated my symptoms. And so with that, my postpartum experience, again, anxiety became elevated just with the repeated pediatric visits that I had to have with my daughter. She started to lose quite a bit of weight, over a pound, in the first couple weeks. And that was, I had a lot of trouble breastfeeding. And so I was doing syringe feeding and all kinds of stuff, which was just really stressful. And then after about a month, I switched to formula. And that actually really triggered some OCD habits for me, particularly around bottle washing. And I was really worried about contamination, and had a very strict setup in my house that really no one was allowed to be around. And so it just, built on top of that anxiety that I already had. When I went to my 6-week checkup, I wasn't screened at my 6-week checkup. And I recall my OB just really kind of saying, how are things going? And we talked a little bit about switching to formula, and that was really kind of it. It was a pretty standard checkup just to see how I was doing physically. And then shortly after that checkup was when I started to have some pretty intense, intrusive thoughts. Some things that I experienced were walking my daughter in the stroller and just pushing her out into the street. And so because of that thought, I just didn't take her out in the stroller. I also had some thoughts about driving over bridges and getting out of my car and jumping off. So I avoided bridges, and a lot of the intrusive thoughts that I had just really started to create this environment for me where I was isolating myself, because I was just so afraid of all of these thoughts actually happening. And so I just stayed home, and it was the fall and kind of gloomy. So it really just all started to create this depressed state. And all of that then sent me looking for help. And I went back to my OB at 2 months postpartum. Before I called my OB office, I had looked at postpartum depression online. I really wasn't sure if that's what it was, because the only story I had in my mind of what postpartum depression was Andrea Yates, because that's just the story that was around before I had gotten pregnant. So I knew that's not what I was experiencing, but I knew something was wrong. And I also really wasn't sure who I needed to reach out to. I felt like I should reach out to a therapist, but I didn't know how to even go about doing that. So I felt most comfortable with my OB since I had seen her so frequently. So when I called to make the appointment to be seen again, I had mentioned that I thought I might have postpartum depression. So they got me in pretty quickly. And because I had mentioned that, they did the first thing they did was do a screening when I saw the nurse. So a nurse did the screening. She was a new nurse that I hadn't seen in any of my visits prior. And it really was not a great experience. My story really kind of touches on what Dr. Gill said around education, because my particular nurse was very uncomfortable giving the screening. And when she got to the last question, which was, do you think that you would hurt yourself or your child? I was having these intrusive thoughts, and so I wasn't really sure how to answer that. But I felt like, that I felt like I didn't know. I really wanted to say, I don't know. And so she looked at me and kind of just shook her head a little and said, no, you would never think that or do that. And just answered the question for me. And so in that moment, I really kind of felt like I'm going to leave here. I'm going to leave this appointment without getting help. And I knew that I really, really needed help. So I just really kind of felt ashamed and afraid to say anything. So I waited for my doctor, and she actually went through most of the questions again with me. And when she got to that last question, she could kind of tell that I was unsure how to answer, and was really able to see that I was really, really struggling, and there was something more serious going on. So once she kind of realized what was going on, she called a therapist for me and made an appointment for me the next day, and really advised me to talk to my husband, because I hadn't shared my feelings with anyone. I was just sort of sitting alone at home with my feelings. My husband was at work, and I didn't have any family in Charleston. They all lived pretty far away. So that's kind of what happened with my diagnosis. And I saw my therapist that my doctor recommended for about 6 months. I began right away on medication for depression and anxiety. And I didn't hesitate to do that only because I had already stopped breastfeeding. And so I wasn't really concerned about that, although that would have been something that would have been hard for me to do if I was breastfeeding. I was not comfortable with my therapist, but I didn't want to look for another person. I really wasn't clicking with her, and I just kind of felt like I was just, moving through my days, pretty flat emotions, and I was just trying to make it. And so after about 6 months, I did end up switching. I found Postpartum Support Charleston, which is our local resource here in Charleston. And they had a couple recommendations for mental health providers that specialized in maternal mental health. And so I finally got the courage to switch to a different provider. And I found a stroller running group where I could bring my daughter with me, because that was something that was still really hard for me with my anxiety, was being separated from my daughter. And so once I found this new therapist and this group of moms, I really started to feel like my recovery was getting better, and I was starting to feel like my normal self again. And so just coming full circle for me, I had, like I said, I received some help from our local organization as part of my recovery, and I just started following them online and watching some of the things that they were posting, and it was pretty helpful for me. And about a year or so postpartum, they were looking for someone to help them with their annual fundraiser. So I started doing that with the group, and then I joined the board. And now I'm the executive director of the organization, and have been doing that for 2 years now. And so some things that I have seen in our community, well, one thing that I've noticed just being an advocate for moms is that every community is different. There are a lot of struggles that we have that the other cities in the country are not having, particularly around peer support. But what I've seen personally in our community with the moms is they do find our peer support and resources to be very helpful once they find us. And so the struggle that we have is that our providers during pregnancy are really not talking about this as an illness that moms will, that moms could potentially have after they have their baby. And so moms are blindsided by their symptoms, and they don't understand what's happening, and they often really feel alone. In my case, I had access to really great care, but I just didn't really receive the help that I needed from the doctors when I should have gotten the help. Eventually, once I realized what was going on, my OB was great, but it would have certainly helped to have that education and screening, at least at my 6-week checkup. And what we're seeing right now from medical providers in the community, this is really like the OBs in the hospitals, is we have noticed an increase in screenings with some of our providers, but it's still not great. It's not something that is required in our state. And I know that some of the OB providers here are still a little hesitant to support moms. I've had conversations with our medical providers here, some that have said, they just don't screen because they're worried of the liability, concerns if the mom doesn't get better. And that's really just them not knowing the great resources that we do have in our community that can help moms. I think Charleston, we're really lucky because we have a great support network and an organization like Postpartum Support Charleston. It's just a matter of educating the moms and letting them know that we are here to help them and that they really are not alone in their struggle. So that's what I have.
Elaine, thank you so much for powerfully sharing your lived experience. You are a very brave mom, and you should be very proud. I want you to know, along with our other viewers, that almost no one dropped off the call, even though we are at the top of the hour. It speaks volumes to the importance and credibility that you shared on your story and the experience that you lived. And I want to thank all of our panelists for contributing to this narrative. It's an incredibly timely and important conversation for us to be having. And during the call today, we received many questions. I want to assure our listeners that we received your questions and we will do our best to answer them. We do want to be respectful of both our panelists' time as well as those of you who have registered today. So we will share a recording of today's webinar. Again, thank you to our panelists and Robert Wood Johnson Foundation for funding today's webinar. You will be directed, as you close your webinar, you'll be directed to a recent issue brief as well as a brief survey that we would welcome you to participate in on maternal depression. Again, thank you to our panelists for sharing your insights and stories and guidance.